Good morning, everyone. Today, my topic is review of Guillain-Barré syndrome. Guillain-Barré syndrome is the most common and most severe acute paralytic neuropathy, with about 1 lakh people developing the disorder every year worldwide. Under the term of GBS are several recognizable variants with distinct clinical and pathological features.
So this is the summary of this slide is, it is not one particular disease. It has got a several recognizable variants with distinct clinical and pathological features. That is one thing. It is most common severe acute paralytic neuropathy. Acute paralytic neuropathy, somebody comes with acute paralytic neuropathy involving the muscular weakness very much more than the sensory. You must think of Guillain-Barré syndrome, and under this there are several types. That is what exactly it says. Okay.
Yes. Coming to the introduction, Guillain-Barré syndrome is usually preceded by infection or other immune stimulation that induces an aberrant autoimmune response targeting peripheral nerves and their spinal roots. Molecular mimicry between microbial and nerve antigens is clearly a major driving force behind the development of this disorder, at least in the case of Campylobacter jejuni infection.
Yeah, the important point here that they are saying, and all we have to learn, is there is what is called an aberrant autoimmune response. Autoimmunity, targeting the peripheral nerve and the spinal. There is an aberrant immune response, autoimmune response triggered by an infection. Okay. And
Yes.
this targets, which is the target for this autoimmune response? Not the joints, not the skin, not the heart, but it is the peripheral nerves and the spinal roots. And what is the mechanism involved? The word should come in your text. Molecular mimicry. This is called a typical description. Molecular mimicry means there are microbial antigens, there are nerve antigens which resemble one another. That is what exactly is called the molecular mimicry. A microbial antigen, particularly CJGNI, and then the nerve antigens could be very similar. So the antibodies manufactured against the organism are working against the neural nerve antigens there and producing the aberrant autoimmune syndrome.
The acute progression of limb weakness, often with sensory and cranial nerve involvement, 1 to 2 weeks after immune stimulation, proceeds to its peak clinical deficit in 2 to 4 weeks. When a patient presents with rapidly progressive paralysis, the diagnosis of GBS needs to be made as soon as possible. And the diagnosis is largely based on clinical patterns because diagnostic biomarkers are not available for most variants of this syndrome. All patients with GBS need meticulous monitoring and supportive care.
Yeah, the point here is, supposing there is a stroke, you can take an MRI or a CT and diagnose. Supposing there is typhoid, you can do a test and find out. Here there is no marker. Diagnosis is basically clinical. No marker. That is one thing. And progressive paralysis is one important thing. If there is a rapidly progressive paralysis in a patient, we must consider the diagnosis of Guillain-Barré. Okay, sensory is very minimal. Cranial involvement can be there in a variant, not in every case. And all this develops for a period of 2 to 4 weeks. Okay, so why we need to monitor the patient very quickly, very closely? Because he is going to develop respiratory paralysis and he will be a case for ventilation immediately. Okay.
Early initiation of intravenous immunoglobulins or plasma exchange is of proven benefit and crucial, especially in patients with rapidly progressive weakness. Because a quarter of patients need artificial ventilation and many develop autonomic disturbances, many patients need admission in the high or intensive care setting. Symptoms peak within 4 weeks, followed by a recovery period that can last months or years as the immune response decays and the peripheral nerve undergoes an endogenous repair process.
Yeah, the point here is there will be a need for artificial ventilation. Why? One, because of autonomic disturbances. Two, because of the development of paralysis, higher center involvement. May develop autonomic disturbances. Artificial ventilation may be needed because of respiratory failure, because of autonomic disturbances, or because of the bulbar involvement where the respiratory, reflexes of the throat, the deglutition and the pharyngeal reflexes are affected, so much so aspiration could be a problem. So for three reasons, I may need to intubate. One, there is autonomic disturbances like severe hypotension and bradycardia or tachycardia. For those to counter, patient will become unconscious. I need to intubate. Or the patient will have an ascending paralysis, respiratory paralysis, or there is weakness of respiratory muscles, is not able to breathe because respiratory muscles are weak and not able to push the air inside. Thirdly, there could be involvement of the bulbar nerves which could result in aspiration. In order to prevent aspiration, I might have to do an intubation. That is a very important. Two important treatments are available, IVIG and PE. PE and IVIG are equally beneficial, but there is no evidence to show that you can combine both. Don't be vigorous and give IVIG as well as plasmaxine. You should not combine both. There are no studies to say that there is a combined benefit of both. Okay.
Okay. Epidemiology and preceding infections. The estimate incident rates of GBS were 0.8 to 1.9 cases per 1 lakh people per year. The annual incidence rate of GBS increases with age, and the disease is slightly more frequent in males than in females.
Okay, next.
Two-thirds of the adult patients report preceding symptoms of either respiratory or gastrointestinal tract infection within 4 weeks of onset of weakness. And many preceding infections have been identified with this disorder, but only for a few microorganisms has an association been shown, out of which the major one is Campylobacter jejuni. Other infections associated with GBS are cytomegalovirus, Epstein-Barr virus, influenza A virus, Mycoplasma pneumoniae, and Haemophilus influenza.
And
The
of course,
nature,
now
sorry,
here, you remember COVID also. Now, we
okay,
have post-COVID Gullian Barrie also is there. Okay.
okay. The nature of the preceding infection affects the clinical phenotype and prognosis. For example, Campylobacter jejuni infection are usually associated with pure motor axonal form and more severe limb weakness and serological antibody response directed against GM1 and GD1A gangliosides. These patients generally have a poorer outcome.
So what they're saying is if you have a CGGNI, trigger as the cause, it could lead to a type called the pure motor axonal type. And this is having very severe muscular weakness, and there is serological markers are there, GM1 and GD1A, and this is associated with a poor prognosis, unlike the sort of a progressive sensory type of this one. Okay. Progressive type.
Yes.
Okay.
Coming to the pathophysiology, immune injury specifically takes place at the myelin sheath and related squamous cell components in acute inflammatory demyelinating polyneuropathy, whereas in motor axonal neuropathy, membranes on the nerve axon, that is axolemma itself, are the primary target for immune-related injury.
Yeah. So there are two components. One is the myelin, the other is the axon, axolemma. So if the myelin sheath is affected and the Schwann cells are affected, it is inflammatory demyelinating polyneuropathy, AIDP. If the axonal neuropathy is there, it is the motor type of neuropathy, acute motor neuropathy. Two types. The injury is different. The site of injury is different. There is a beautiful diagram I will show you at the end of the presentation, which demonstrates this visually to our eyes. Okay.
Classification into acute motor axonal neuropathy or acute inflammatory demyelinating polyneuropathy was first based on electrophysiological and pathological studies, but was subsequently supported by the identification of specific antibody biomarkers for acute motor axonal neuropathy directed against neural membrane gangliosides, that is GM1 and GD1. The disorder is mainly a humoral mediated rather than T cell mediated in the progressive phase of nerve
That
injury.
is another thing. Last time also I asked. It is basically a B cell mediated injury
Yes.
rather than a T cell mediated injury. And this particular variant, yeah, acute motor axonal neuropathy, it is also called the AMAN, acute motor axonal neuropathy called AMAN. Associated markers are there, GM1 and GD1A. And the other one which is associated with the marker is the Miller-Fisher type. Whereas in the progressive neuropathy, we don't have the markers very much. So when there is acute motor axonal neuropathy suspect, you can do a GM1 antibody and a ganglioside antibody or GD1A antibody. This MN is associated with those antibodies. Okay.
The molecular mimics are glycans that are sugars expressed on the lipooligosaccharides of preceding infectious organisms
Hmm.
that are capable of inducing antibody response to these carbohydrate antigens. These anti-carbohydrate antibody response are believed to be largely independent of T cells. Anti-lipooligosaccharide antibodies can then bind to structurally identical glycans present on the nerve gangliosides. And these anti-ganglioside antibodies in acute motor axon neuropathy are complement fixing and mainly bind to GM1 and GD1A gangliosides.
Yeah. So here the point here is what he's saying is the microorganism is there. They have the surface. The surface coat will have glycans. Glycans are sugars. These are called the lipooligosaccharides. These are the sugars on the outer covering of the organism, particularly Campylobacter jejuni. And these lipooligosaccharides, their short form is LOS, and there are antibodies developing against the LOS. So these are anti-LOS antibodies as far as the C. jejuni is concerned. Where are the glycans present? These glycans are present on the neuronal cells there. So antibodies of this LOS go and interact with structurally identical glycans which are present on the nerve gangliosides. And that results in the immune injury to the axons. This is very much prominent in the motor neuropathy, acute motor axonal neuropathy or MM. And these antibodies are complement fixing. Why do I know that? Because if it is complement fixing, I can measure the C5 complement. There will be a depletion in the C5 complement when this particular reaction is taking place. So one test could be a depletion of C5 component of the complement because it is a complement fixing antibody. Okay.
Yes.
So these are the points you need to know. The lipooligosaccharides are the sugars there, and antibodies to that LOS will be present on the similar glycans that are present on the nerve cells, gangliosides, and these are complement fixing. Okay. Now, this is molecular mimicry.
They induce axonal injury by fixing complement, recruiting macrophages, and depositing membranatic complex in the axolemmal membrane. This immunological cascade disrupts the anatomical and physiological integrity of exposed nerve membranes in nerve terminals and nodes of Ranvier, causing a nerve
Hello.
cases results in severe widespread axon degeneration with poor recovery.
Okay.
Miller-Fisher syndrome associated with anti-GQ1B antibodies in which GQ1B ganglioside is the antigenic target and is disproportionately enriched in the motor nerves that innervate the extraocular muscles.
You see, the pathogenesis is very clear. MFS is associated with the anti-GQ1B antibodies. What are these anti-GQ antibodies? Antibodies directly against the anti-GQ component of the ganglioside. Where are these anti-GQ1Bs are there? They are present mostly on the extraocular muscles. The nerves that innervate the extraocular muscles. So extraocular nerves. That is why there is ophthalmoplegia. Ophthalmoplegia, ataxia will be the feature here. Okay.
So in Campylobacter jejuni infection, only the acute motor axon neuropathy will be developed. And there are two reasons for this. And one is the only small proportion of Campylobacter jejuni strains have ganglioside mimics on their LOS. Most strains bear other glycans. And the second one is most individuals who have been exposed to Campylobacter jejuni maintain immunological tolerance to the self-glycans on the LOS and instead mount a projective immune response against other components of the bacterial surface.
What did you understand out of this?
So only few strains have the ganglioside mixer, and most of the strains do not bear the that ganglioside structure related gangliosides.
Hmm.
And the other is some individuals maintain the immunological tolerance to these self glycans, that is structurally mimicking the antigens present on the
See,
microorganisms.
what you have to understand is molecular mimicry is taking place. What is the mimicry? Resemblance. There are LOS on the bacterial side. There are no gangliosides there. There are LOS or the saccharide moieties are there. These moieties are very similar to the gangliosides on the nerves. Gangliosides are on the nerve side. LOS is on the bacterial side. The LOS glycans are very similar to the ganglioside glycans. Luckily, Majority of the LOS glycans which are mimicking the ganglioside glycans are absent in the C. jejuni. Only few infections have that. Otherwise, everybody who has a C. jejuni would have had a Guillain-Barre. That is one good thing. The second thing is there is what is called this molecular mimicry. Though it is there, the body develops a tolerance. The glycans of the neurons, the exolemma and the myelin sheath, they develop a tolerance to the antibody. And though there is a chance for autoimmunity, this immunological tolerance prevents the nerve injury. These are the two mechanisms. One, the LOS types present on the C. jejuni mostly are not the same as the glycans on the gangliosides. Mostly. That is one reason. Second thing is, even if the LOS are the same as the as the glycans on the nerves, still the body tries to ward off the autoimmunity by a mechanism called immunological tolerance.
The immunological cascade involved in acute inflammatory demyelinating polyneuropathy is less well understood. A wide range of immune stimulants cause acute inflammatory demyelinating polyneuropathy compared with motor axon neuropathy, which induces bacterial and viral infections and vaccines.
There are three types: AMAN, AMSAN, AIDP. AIDP, the immunology is not that very well worked out. AMAN very well worked out. AMSAN to some extent. MFS very well worked out, but not with the AIDP. That's what they're telling. Okay.
Yes. Clinical features and diagnosis. There is a diagnostic criteria but for Guillain-Barre syndrome. The features needed for diagnosis of GPS in clinical practice are progressive weakness in legs and arms, initially only in legs, and areflexia or decreased tendon reflexes in weak limbs. Additional symptoms are progressive phase days up to 4 weeks, relative symmetry in the weakness, mild sensory symptoms or signs not present in acute motor axon neuropathy, and cranial nerve involvement, especially in bilateral weakness of facial muscles, and the autonomic dysfunction and the pain.
Okay. Now, what they're saying is this is more a clinical diagnosis. Not much help comes from any scans or any other test. Antibodies are not always positive, and all types are also not exhibiting the antibodies. For example, the AIDP doesn't exhibit much of antibodies. MSAN doesn't exhibit much of antibodies. The MN and MFS only will exhibit the antibodies. That too, not everybody will develop the antibodies. So the diagnosis left with is only the clinical. How do I suspect? Progressive muscular weakness of legs and arms, starting with the legs initially and going. And this is a flaccid reflexive paralysis. So if any person having a progressive symmetric paralysis, a reflexive paralysis, we must consider Guillain-Barre. And it is over a period of 2 to 4 weeks. And another beauty is this is a symmetric paralysis. Whereas suppose cord involvement is there, it is asymmetric paralysis. And sensory symptoms are rather rare or absent and may be present in the AIDP type, not in the AMAN type or the Muller-Fisher type. AIDP type might have some sensory changes, but sensory is not the dominant one. The dominant effect is flaccid reflexic paralysis, progressive, starting from the lower limbs to the upper limbs. Of course, cranial nerve involvement can be there when the by the bulbar involvement with the Miller-Fisher syndrome, or even the paralysis of the AMN also can extend upwards. Autonomic dysfunction is a feature of Guillain-Barre syndrome, and pain may be there. It could be root pain, it could be nerve pain. Both types of pains are possible. Okay.
Features that should raise doubt about the diagnosis of GBS are in CSF, increased number of mononuclear cells or polymorphonuclear cells, that is more than 50 cells per microliter, and there is a cytoalbumic dissociation characteristic to this GBS, that is the cell counts are normal with increased CSF protein.
Correct.
Yes, sir. Severe pulmonary dysfunction with little or no limb weakness at the onset. Severe sensory signs with little or no weakness at onset. Bladder or bowel dysfunction at onset. Fever at onset. Sharp spinal cord sensory level. Marked persistent asymmetry of weakness. Persistent bladder or bowel dysfunction. slow progression of weakness and without respiratory involvement. Consider subacute inflammatory demyelinating polyneuropathy or acute onset chronic inflammatory demyelinating polyneuropathy.
Now, this is a beautiful way of looking at the clinical sense. What are the positive signs we have seen in the previous slide? What are the negative features which will rule out GBS? Because GBS is a clinical diagnosis, I must have some negative yardsticks. If there is albuminocytological reversal is not present, that the cells also have increased along with the protein, it is unlikely to be GBS because it is a immune mediated protein raise rather than the inflammatory or infective protein raise. If there is infective protein raise, we expect the cells also to raise. If it is immune mediated, cells will be normal, protein is elevated. Second thing is severe pulmonary dysfunction, no limb weakness. Very unlikely to be GBS because the presentation is limb weakness and progressing on to pulmonary dysfunction. But the other way around, severe pulmonary dysfunction is there, no limb weakness is there. That is not probably Gullian-Barre. Severe sensory signs, very little or motor involvement, again unlikely to be Gullian-Barre. Bladder and bowel dysfunction to start with, unlikely to be Gullian-Barre. If that is the case, it is probably a conus lesion. Fever may be there 2 weeks before, but fever at the onset of paralysis is usually against the Gullian-Barre. Short spinal cord sensory level again tells me that it is transverse myelitis or something affecting the spinal cord rather than the peripheral nerves and the roots. Marked persistent asymmetry of the weakness. Symmetric weakness, Gullian-Barre.
Yes.
Asymmetric weakness, non-Gullian-Barre. Persistent bladder and bowel dysfunction. And the weakness is very slowly progressive without respiratory involvement over a period of 6 months, 8 months, 1 year, 2 years, no respiratory involvement. Weakness is slowly progressive. Mostly it is a spinal cord lesion and not Gullian-Barre. So these are the very important negative points which will rule out Gullian-Barre. Okay.
Nerve conduction studies can be helpful in clinical practice but are generally not required to diagnose GBS. Needed to meet all Brighton criteria for the GBS, essential for classification of GBS in acute inflammatory demyelinating polyneuropathy or acute motor axonal neuropathy. Acute inflammatory demyelinating polyneuropathy, the nerve conduction study features are demyelination, that is decreased motor nerve conduction velocity, prolonged distal motor latency, increased F wave latency, conduction blocks, and temporal dispersion. And coming to the acute motor axonal neuropathy, there are no features of demyelination. And one demyelinating feature in one nerve, if the distal CAMP amplitude is less than 10% lower level of normal, can be found. Distal CAMP amplitude less than 80% in at least 2 nerves. Transient motor nerve conduction studies might be present.
Okay, I have another slide which will tell you what is AIDP, what are AMAN, and what is AMSAN. So I will show you that slide at the end, and this is a little confusing description these people have given, but in that slide it is very clear. We will go to that. Okay.
Classification of GBS as either AIDP or AMAN is not required for the diagnosis. Whether the both conditions require definite treatment options is unknown, and the amount of conduction slowing required to define demyelination differs between the classification systems.
Now the point here, what we are telling here in this slide is, I don't require to know whether it is AIDP or AMAN or AMSAN or MFS. All I require to know is make a diagnosis and watch for the respiratory involvement and start and ventilatory support whenever. That is all I require. And of course, the treatment is same, whatever may be the type of this one. I have only 2 treatment options, either the PE or I have the IVIG. So that's all I need to know. But this is a clinical interest to know whether it is, axonal type or it is the Schwann cell and myelin type. So if I know that, I can predict the prognosis because the AMAN is rapidly progressive and it could end up in respiratory failure, unlike AIDP. For that reason, I need to know, not for making a diagnosis. Okay.
Yes. These are the differential diagnosis of rapidly progressive limb weakness with or without respiratory failure. Coming to CNS, there are encephalitis, acute disseminated encephalomyelitis, transverse myelitis, brainstem or myelin compression, and leptomeningeal malignancies. Yeah. Coming to the motor neuron diseases, include poliomyelitis, West Nile virus enteromyelitis, amyotrophic lateral sclerosis, progressive spinal muscular atrophy,
Hmm.
plexus injury, neurologic amyotrophy, and diabetes mellitus.
How do I differentiate them? These are different diagnoses. Encephalitis, there will be involvement, more involvement of the brain and unconsciousness, and then there will be transverse myelitis. I have a different transverse level, and at the level of
Yes,
lesion there will be lower motor neuron, and below the level of lesion there will be upper motor neuron, and brainstem. Involvement. I know when there is brainstem tumors and brainstem injuries, and what sort of crossed hemiplegias and all those things it can cause, and leptomeningeal malignancy deposits also similar thing. When you come to motor and motor neuron disease, there are definitely features of upper motor and lower motor neuron combined, and it is not transsectional, it is ascending, not even ascending, it is cut off, it is diffuse, and then I know there will be involvement of upper, lower limbs of different types, asymmetrical, motor weakness mainly, it will be there. Suppose there is a plexus involvement, there will be neurologic pain of the plexus, brachial plexus or lumbar plexus, whatever it is, and usually involvement of the peripheral nerves can be due to diabetes also, and that could be understood. Now, nerve roots.
Now, roots, GBS, acute onset chronic inflammatory demyelinating neuropathy, Lyme disease, cytomegalovirus related radiculitis, HIV related radiculitis, leptomeningeal malignancies again,
Correct.
and involving the peripheral nerves or the again GBS, and acute onset chronic inflammatory demyelinating neuropathy, iatrogenic toxic critical illness myopathy neuropathy, vasculitis, diphtheria, porphyria, thiamine deficiency, and Lyme disease, metabolic or electrolyte disorders, and
Hypokalemia, phosphatemia.
phosphatemia or magnesemia, hypoglycemia
Okay.
of the electrolyte. And neuromuscular junction involved or myasthenia gravis, botulism, intoxication.
Correct.
The disease targeting the muscles or critical illness, myopathy, neuropathy, mitochondrial disease, acute rhabdomyolysis, polymyositis, dermatomyositis.
So there's depending on the various areas where the nervous system can be involved, there are different differential diagnoses. If you have features of peripheral nerve involvement, this is the difference. If you have features suggestive of muscle weakness, this is the difference. If there is the radicular involvement like picture is there, this is the differential diagnosis. That's what they are saying. Now come on, come to the treatment.
Coming to the treatment guidelines,
Yeah.
this is an algorithm for the treatment approach to the GBS.
Hmm.
Once the diagnosis is made about the GBS, admission to ICU and high care or general neurological ward, considering prognostic model, that is
Egress
just a,
model.
yes, sir,
Other
I
day we
guess
have
not.
seen, again I will show you the Tigris model, no problem.
Okay, okay.
Mm.
And if the patient is unable to walk unaided, especially when less than 2 weeks from onset of weakness,
Mm.
treatment indication with IV immunoglobulins 1 to 4 gram per kg daily for 5 days or plasma exchange. Mildly affected patients with GBS check for further deterioration or treatment indication.
Mm.
Uh, Parallelly, check regularly for initial every 1 to 3 years for respiration, progressive weakness, swallowing difficulties, autonomic dysfunction, and pain.
That's very important because
Yes, sir.
the main important thing is we should know when we require to ventilate. I told you there are three good reasons to ventilate. One, there is progressive respiratory paralysis endangering the life of the patient. That is involvement of the respiratory center. The second thing is patient doesn't have any respiratory center failure, but it's a peripheral failure. The muscles are not contracting properly because of muscular weakness, and
Yes.
the chest muscles are not able to fill the air, and then the movement of the rib cage is not there. In that case also it requires ventilation. Third thing is there is involvement of the cranial nerves of the bulbar region, and that produces some sort of reflex disturbances in the deglutition as well as in the pharyngeal reflexes, which could end up in aspiration. So for these three reasons you need to intubate. One, respiratory paralysis involving the respiratory center. Two, the peripheral muscular failure and not able to pump enough air into the chest, draw enough air into the chest. Three, when there is associated cranial nerve involvement of the lower cranial nerve involvement, which might result in aspiration or any of the problems related to the cranial nerve involvement. And this is the situation, or the fourth one, of course, is the autonomic disturbance. Patient is sinking, you want to give him vigorous treatment, then he requires intubation. Write down the 4 reasons for intubation. You have to write down you have not summarized. Now I am summarizing. 4 reasons are: 1, acute respiratory failure because of respiratory center involvement. Number 2, peripheral respiratory failure because of the muscle weakness. Number 2.
Yes, sir.
Number 3, when there is a sort of pharyngeal reflex involvement, the palatopharyngeal and then the pharyngeal reflexes are affected, then naturally the swallowing will be a problem, and there could be aspiration pneumonia. To prevent that, I put the patient on intubation. Fourth, severe autonomic dysfunction, which necessitates higher care. We require to intubate the patient. Okay.
Okay.
And the treatment of this one is IVIG 0.4 kilogram for 4 grams or 400 milligrams per kilogram
Yes, sir.
body weight for 5 days. It can be given, as I told you last time. You can give in 1 gram on the first day, 1 gram on the second day per kg, or you can spread it over 0.4 into 5 days. Both are possible depending upon the patient's rapidity of progress and involvement. Both are possible, both are accepted. Okay.
Okay.
Okay. Plasma
Coming to
exchange,
the
if you think of
yes,
plasma exchange, what you have to do is you have to give around 200 to 300 ml of plasma every day for a period of 5 to 7 days.
yes. Consider treatment-related fluctuation after IV immunoglobulins or plasma exchange. That is deterioration with after initial stabilization or improvement, and retreatment with IgG or plasma exchange is considered.
Yeah, these are possible. What happens is you give the treatment, then there will be treatment related fluctuation. Patient's attendants will come and, sir, you have given the special injection. It is very costly, you said, and I paid the money. The patient again had the problem. Yes, this is expected. Treatment related fluctuations are expected, and he may require a retreatment. What are the complications can occur? Bed sores, pulmonary infections, venous thrombosis. You keep
Yes,
monitoring for the venous thrombosis. Look at the D dimer, and the stage will come where you may have to prevent pulmonary embolism and DVT also. You may have to put him on low molecular weight heparin. That's very important. For
okay,
bed sores, pulmonary infections, and of course VTE and PE are important complications. Okay.
okay.
Now,
And there is another condition that is acute onset chronic inflammatory demyelinating polyneuropathy. If there is 3 or more deteriorations, that is treatment-related fluctuations or any deterioration after 8 weeks, require consideration of retreatment with immunoglobulins or with steroids, as for chronic inflammatory demyelinating polyneuropathy. For check for consider discharge to neurology ward or rehabilitation center or home for the delayed disability complications, and consider physiotherapy, rehabilitation, and psychological help and patient support.
correct. Now the point here is steroids are indicated only it is an acute and chronic. Otherwise, if there is a chronic progressive demyelinating polyneuropathy is already patient has got. On top of that, he developed this acute condition and there are treatment related failures. Then there is an indication for steroid. Several randomized trials have conclusively proved that corticosteroids have got no benefit in these patients, in fact harmful. Earlier when we were students, we don't have the IVIG, we don't have the plasma exchange. We only have the steroids in our hand, and every patient of Gullian-Barre, we were forced to put them on the steroids in the hope that the immune inflammation will be countered by the anti-inflammatory steroid. But later on, in the last 10-15 years, the RCTs have shown steroids are not beneficial. Today, as a practitioner of medicine, you should drop the unlearn that steroid use and use IVIG or plasma exchange. The problem with these two treatment, they are not readily available, particularly plasma exchange, and secondly, they are very expensive. Okay,
Okay.
next.
Both oral steroids and intravenous methylprednisolone are not beneficial in this disorder.
Correct.
Combination of plasma exchange followed by immunoglobulins is not significantly better than plasma exchange follow or giving immunoglobulins
That
alone.
is important. You cannot combine. The studies have shown that the combination of these two, IVIG and PE, is not helpful. Either one is adequate. You should not combine IVIG with plasma exchange or vice versa. So you should not combine this first and later on that, not like that. Either this or that only should be used, and steroids, of course, have no role now. There is an antibody there. You read about that.
Yeah, eculizumab, a humanized monoclonal antibody that binds with high affinity to the complement factor C5 and prevents its cleavage to C5a and the pro-inflammatory cytolytic C5b B9 complex.
That is what we have earlier learned. No, the complement fixation, the
Yes, sir.
immunological injury is happening due to complement fixation. So that is C5 is involved. C5
Yes, sir.
has to be cleaved to its active C5a. That cleavage is interfered by the eculizumab. So that's why when the C5 cleavage is not there, it is not active. When it is not active, it cannot function to fix the the antibodies onto the ganglioside moieties there. So that is how the eculizumab prevents that. Okay,
Yes, sir. At present, only immunoglobulin and plasma exchange are proven effective treatments for the GBS.
correct. That's what you have to learn. Now, electrophysiology.
Electrophysiological classification. It is the classification is done to support the diagnosis, to discriminate between axonal and demyelinating subtypes, and relate to the prognosis. Abnormalities are most pronounced 2 weeks after the start of weakness. To increase the diagnostic yield, at least 4 motor nerves, 3 sensory nerves, F waves, and H reflexes should be examined.
That's what you have to at least look for motor as well as sensory nerves, and look for F waves, and look for, and this is required only to support the diagnosis and not to make
Yes,
the diagnosis. Second, it is required to distinguish between AIDP and the MN. Why I need to discriminate them? The prognosis is different
yes.
for that reason. Okay.
And
AIDP.
electrophysiological changes in AIDP or the signs of demyelination, as discussed earlier, that is prolonged distal motor latency, decreased nerve conduction velocity, prolonged F wave latency, increased temporal dispersion, and conduction blocks. A
Correct. These are the
sural
four
sensory,
things.
yes, sir.
Yeah.
Sural sensory potential is often preserved.
Hmm.
Features of the axonal variant of GBS are decreased motor, sensory, or both amplitudes.
Yeah, so see, there is a difference, because in one case it is the myelin sheath affected, and here it is the axolemma that is affected. That is why they say nerve conduction features will be different. So this distal motor latency, reduced NCV, and then the F wave latency, prolonged F wave latency, and then increase the temporal dispersion and conduction blocks. Because the nodes of Ranvier are affected. Once the myelin is affected, the nodes of Ranvier are affected. And then once the myelin is demyelinated, there will be conduction of the nerve impulses on the axon will be very slow. That is why the nerve conduction velocities will be slowed. Unlike in axonal neuropathy, where the myelin sheath is intact, but then the axons are affected. Axolemma is affected. Okay.
Yes. Nerve conduction studies might also have prognostic value because the patients with features of demyelination are often needed mechanical ventilation, and low compound muscle action potentials are the most consistent finding predictive of poor outcome.
What does this mean? It means that if you have muscle action potentials are very low, that means it is motor neuropathy. Yeah, I mean, a man has got a poor prognosis. Okay. Now,
The treatment-related fluctuations and acute onset chronic inflammatory demyelinating neuropathy. About 10% of patients treated with immunoglobulin or plasma exchange will deteriorate after initial improvement or stabilization. That is called treatment-related fluctuation. These treatment-related fluctuations usually occur within the first 8 weeks after start of treatment. Repeated treatment has been observed to be beneficial in these patients. That is 2 gram IV immunoglobulin per kg in for 2 to 5 days. In
correct.
these patients, prolonged immune response that causes sustained nerve damage or functional blockage, which needs more prolonged treatment than standard care.
Why this is important for us? When you start on the treatment, You have to tell the patient's relatives, and the patient also will be conscious. So I'm giving you the treatment. 90% of time you will improve, but there is a chance that 10% of the time again the symptoms may worsen. Don't worry. We have one more round of treatment. Then in that case has to be given. You have to counsel a priori. This will prevent unnecessary complications with the relatives. Oh, you have given a very expensive treatment, but the disease has become now more like that. They should not think. So if this is a nature of the treatment is like that, it is not that you have done any damage willfully. The nature of the treatment is 10% of the people will have a TRF, and the TRF requires retreatment.
Some patients initially diagnosed with GBS can have several episodes of deterioration further. The diagnosis of acute onset chronic inflammatory neuropathy should especially be considered in patients initially diagnosed with GBS who have 3 or more periods with clinical deterioration, or when there is new deterioration after 8 weeks from onset of weakness. These secondary deteriorations should be recognized because patients with GBS with a treatment-related fluctuation might improve after retreatment, and patients with acute onset chronic inflammatory demyelinating neuropathy usually need chronic maintenance treatment with immunoglobulin or switch to a corticosteroid treatment.
That's a different category. A person who has got chronic inflammatory demyelinating, you may continue the IVIG periodically, or if it is too unaffordable, then you may have to put them on steroids. Unlike the fellow who has got TRF, second treatment, he will become all right. That is the difference. Okay.
Outcome and prediction. GBS is still a life-threatening disorder with frequent morbidities, even with the best treatment available. Mortality rates vary between 3 to 7%, and patient can die in the acute progressive stage, most probably because of ventilatory insufficiency or pulmonary complications, or from autonomic dysfunction, including arrhythmia.
Correct.
Death can occur at a late stage when a patient is discharged from an ICU to general ward, which further shows the importance of prolonged, accurate monitoring and general care.
Yeah, it can be immediate in the acute phase,
Yes,
or it can be late deaths also can occur. That is why monitoring for a long time is required. And it is a disease with 7% mortality. So even COVID doesn't produce 7% mortality. Even somebody has got COVID disease, the mortality in India is 1.4%. Look here, a disease which is 3 to 7% mortality, isn't it? So very
yes.
severe disease. Okay. Go ahead.
Patients who survive GBS frequently have residual complaints and deficits, which can have a substantial effect on daily activities and quality of life.
Yeah.
About 20% of patients cannot walk unaided 6 months after onset. Most patients have residual pain and fatigue, which can in part be attributed to persistent axonal loss. Most improvement happens in the first year, but patients might show further recovery even after 3 or more years.
Yeah, there is nothing need to, some people will have a prolonged illness and they may even take a few years to completely recover. That's what they're saying. Okay.
The clinical course and outcome of the disease is highly variable, and early recognition of patients with poor outcome is needed to personalize and improve treatment. The characteristics related to poor prognostic outcome are advanced age, that is aged above 40 years, and preceding bacteria or suggesting the Campylobacter jejuni infection in the past 4 weeks, and high disability at NAD.
So this is the thing. The disease has occurred and the disability has peaked very early. So that is what is called the high disability at NIDR. The EGOs.
Sir, Erasmus, which is based on these three clinical characteristics can be used 2 weeks after admission to predict the ability of the patient to walk at 6 months.
These are some predictors. EGO score is a predictor depending on this age and then preceding diarrhea and high disability at the NIDR are the poor prognostic signs. Okay.
The risk of respiratory failure is associated with rate of disease progression, severity of limb weakness, and peroneal nerve conduction block, and low vital capacity. The risk can be predicted for individual patients using a risk score based on severity of weakness, onset of weakness, and facial palsy, bulbar weakness, or both. These models need to be validated for use in children and patients with axonal forms of GBS.
Now, when do I say that there is respiratory weakness. What are the sort of the, I know, we clinically we know, but there must be some definite yardsticks to say there is respiratory weakness of the muscles. When do you say that? One, vital capacity. Okay. If the forced
Okay.
vital capacity is less than 1 liter, okay, or 15 ml per kilogram body weight. 15 ml of per kilogram body weight, 60 kilos, 60 into 15 is 900 ml. That is around 1 liter of vital capacity. The second thing is inspiratory negative pressure more than 40. That means patient requires more negative pressure to fill the lungs. Okay. Number three is when there is a hypotension. I mean, this you use your SpO2 and there is a lower SpO2 less than around 85 or something like that. So these are the three parameters. What is the vital capacity? Every 3 hours we have to look at. We can't wait every 2 days. You're not like that because suddenly they will progress. So for that reason, what you have to look at is look at the vital capacity, 15 ml per kg body weight if he is a thin fellow or a very thick fellow, or on an average 1 liter of vital capacity or less. What is the normal vital capacity? 2.5 to 3 liters is the normal force vital capacity. Anything less than 1 is going into deterioration. Number 2, if the inspiratory pressure, while recording that, you know, minus inspiratory feeling pressure is more than, I mean, minus 40, that is, it is more negative pressure is required to fill the lungs, then again he requires support. The third thing is when there is the SpO2 is coming down. These are the three indications that you may require the ventilation for peripheral reason. I told you the reason, 4 reasons are there. One peripheral reason, one central respiratory center failure, 3 the reflexes of the lower cranial nerves, and 4 the autonomic disturbances. Any 4 will require you to do the intubation. The peripheral reason can be assessed by these 3 things. Conclusion.
Conclusion. The first description of GBS that are rapidly advancing understanding of the pathological mechanisms of the disease is informing new treatment strategies and approaches to clinical care. Treatments have been developed and proved effective, but these are not sufficient in many patients. Newly emerging post-infectious forms of GBS, such as those associated with arbovirus, including Zika, need to be closely monitored as a global epidemic spread. Biomarkers.
Even COVID also, for that matter, it was not known when the article was written. There was no COVID. Now
Yes, sir.
COVID, the GBS, we know.
Yes. Okay.
Biomarkers.
Biomarkers, prognostic models, and better therapies are needed. Prevention of severe axonal injury early in the course of the disease remains a major focus because it is an important limiting factor in achieving a good long-term outcome.
Correct. So these are some of the slides which I prepared
Yes.
in addition to what she has prepared. You can see here in this slide that so you can see in this slide that the weeks, months, and years is on the x-axis. Severity is on the y-axis. The first red curve is the infection 1-2 weeks, 2 to 4 weeks. Then the serum antibodies and gangliosides are in the purple color. The purple or blue color line is the occurrence of antibodies and their I mean sort of waning of the antibodies occurs by around 6 weeks to 8 weeks. So progression phase, plateau phase, recovery phase, disability phase. This is clinically. So the infection part, jejunal infection, 2 to 4 weeks before, then the antibodies from 2 weeks to 8 weeks or 10 weeks, and the clinically from 2 to 3 weeks, the clinical thing starts and goes on for years. This will tell the infection part, I mean antibody monitoring. Supposing I want to look at the antibodies after 2 months or 3 months. There is no use because by then the antibodies would have waned. But clinically, there will be some residual symptoms. Progressive phase, plateau phase, recovery phase, disability phase. Now, so this is exactly the nice way of representing. Look at the spinal cord there. So this is the anterior horn cell, the posterior horn, this is the spinal cord. So this is the normal picture. That means the nerve has come out, nerve root, and it is going to the muscle. The myelin is intact and the axon is intact, and there is conduction is beautiful. That means the electrical wire outer plastic cover is intact. The inner copper wire is also intact. Whereas you look at the AIDP, this is AIDP. The AIDP, the copper wire is okay inside, but then the outer plastic covering is completely disturbed. That why, because there is an antibodies which are onto the glycans on the neuroglycans on the myelin sheath, demyelinating. What happens when it is there? Then there is short circuiting occurs. When there is a no this one, and then the nerve conduction is dependent upon the integrity of the myelin. So all demyelinating diseases we are getting nerve features because of demyelination. In the absence of the covering, the myelin sheath, the nerve conduction suffers. This is the AID. You look here, this is the Yaman. In the Yaman, what happens then? The sheath is all right. There is no problem with the myelin sheath, but then, can you see?
Yes, sir.
Yeah, the myelin is not affected, but the integrity of the axon is affected, axolemma is affected, and it is disturbed at the nodes of Ranvier, node of Ranvier. So there is a discontinuity in the conduction in the motor nerve. This is more dangerous. Okay. So this is how the antibodies are acting. In this case on the myelin, in this case on the axolemma. And this is the normal picture. Very nice picture to understand what exactly is happening. Look here. Clinical features of Gullian Barrie: motor dysfunction, sensory dysfunction, autonomic dysfunction. Motor dysfunction: symmetric limb weakness, proximal, distal or global, neck muscle weakness, respiratory muscle weakness, cranial nerve paralysis of the oculomotor nerves and the facial nerve, and then the pharyngeal nerves 9 and 12. 9, 12, 7, and then the oculomotor nerve. Areflexia, wasting of the limb muscle. Sensory, pain and numbness and paresthesia, particularly in the sensory type, that is AM, SAM, and not in the AMA. Autonomic, sinus tachycardia or bradycardia, cardiac arrhythmias, hypotension, postal hypotension, wide fluctuations, BP and pulse, tonic pupils, hypersalivation or hyposalivation, anhidrosis, excessive sweating, hyperhidrosis, sphincter involvement, constipation, gastric motility. These are all autonomic features. So there are motor, sensory, and autonomic. What are the electrophysiological features? This table very clearly tells you the electrophysiology. AEDP, reduced conduction velocity. Sorry, reduced conduction velocity. Conduction block or abnormal temporal dispersion. Prolonged terminal latency. Absence of F wave or prolonged F wave occurs very late. These are the features of acute inflammatory demyelinating polyneuropathy. Reduced CNV, conduction block or abnormal temporal dispersion, terminal latencies, prolonged EF waves may be absent or they are occurring very late. The YAMAN, that is acute motor neuropathy, in that absence or reduced compound muscle action potential. What is CMP? These are the action potential generated through the motor nerve, the conduction occurs. If they are not there, means what? The motor conduction is affected. But motor terminal latency is normal and conduction velocity may be normal because it is not the myelin sheath that is affected, but it is the axolemma and the axon that is affected. Sensory nerve action potentials are normal, only the CAMP, motor action potentials, are reduced or absent. In AM scan, a picture of both reduced SNAP, reduced CAMP together will be there. Is it now easy to understand the differences looking at this table?
Yes.
Yeah, unlike the description, this puts you in a very clear this one. If the NCV is reduced, if there is no F wave or prolonged F wave latency, or there is conduction velocity is reduced, it is AIDP. If the CAMPs are absent or delayed, and it is AIM. If both SA and the SNAP, that is sensory action potentials and motor action potential, both are involved, it is AMSCAN. Okay. Now,
Yes, sir.
what investigations I do, which we have not covered in the paper, CSF, antiganglioside antibodies, stool culture, of course, look for the causative organisms, urea electrolytes for the metabolic stability, blood count, ESR, ECG for your arrhythmias and all, autonomic function testing, electrophysiology. What are the factors which are associated with poor prognosis? You said three things there. One, the age, two, the Campylobacter, and three, the motor neuropathy.
Disabled. Yes.
Okay, here, Campylobacter, previous GE infection, cytomegalovirus, a older age, short latency to NIDA, that is, very quickly the disease is progressing.
Yes.
Longer time to clinical improvement, person who is leading mechanical ventilation, greater disability and disease severity. Electrophysiologically, CAMP are absent, motor component. So naturally they are at a poor prognosis. Or nerves are inexcitable at all, that is even worse. Biochemical, those who have the antibodies, and definitely they are at a poor prognosis. This table is excellent in terms of predicting the prognosis.